Good morning, students. So, I'm Dr. Kanksha Singh. I'll be going to take a very short and crispy lecture on acute gingival infections. So, before proceeding to my topic, I'd like to say that gingiva is the smallest tissue of our oral cavity. So, knowing, well, not a little bit, but more about gingival infections is really important. And this is the most ignorant part, which most of the people avoid because they think that it can be healed or it can be treated or it can't be treated, even then they get better. So let's emphasize on this topic. So further, if I talk about my contents will be necrotizing ulcerative gingivitis. We'll be talking about primary herpetic gingivostomatitis. We'll be talking about pericornitis and their treatment modalities, right? Next, let's talk about our first topic, that is necrotizing ulcerative gingivitis. So, the acute gingival infection, the name acute here stands for the, sudden onset diseases, which have, sudden pain, sudden bleeding, which are having some sudden onsets. So, when we talk about the introduction and the history part, the unique disease among all the periodontal disease. It has acute clinical presentation. Again, when we talk about acute, it means sudden. They have a rapid onset of gingival pain, bleeding, interdental gingival necrosis. It has been recognized for centuries that when you have heard about one topic, that is acute necrotizing ulcerative gingivitis, which is also known as ANUG, or it also earlier used to be called as trench mouth, trench ulcer. So it's all started from the earlier historical documentation at the times of war. In the 4th century, the first documentation in the historical war in the records of Xenophon's troop. So during that time in the war, this type of gingival disease was first time noticed. Then again, while in the Roman army, 1st century AD, it was again noted. While in 1778, there were so many clinical features which were very similar to necrotizing ulcerative gingivitis, scurvy, and chronic periodontitis. Then in the 19th century, again, which when I called it French mouth, so that was very common in French tubes. And it is also known by so many common names such as Vincent disease, fusospirochetal gingivitis. Why fusospirochetal? Which I'll further explain you when I'll be discussing about the etiopathogenesis. French mouth, acute ulcerative gingivitis, acute necrotizing ulcerative gingivitis, and let me also tell you one thing, that according to 2017 classification, again, the terminologies have been changed. Next, when I'm talking about the definitions, you can see how in this picture how the gums and the infection spreaded and slowly the gingiva degenerates. So it is a microbial disease of the gingiva in the context of the impaired host response. So it's a two-way thing. Means when the bacteria comes and it attacks our gums, in the response, our host also shows some reaction. So there is some impairment in the host activity or the host response, which is characterized by the death and sloughing of gingival tissue and presents with characteristics of sign and symptoms. So again, we can also call it is a non-contagious anaerobic infection, and it is associated with major two bacteria, that is Borrelia vincenti and fusiform bacteria. Now, when we talk about the characteristics features of necrotizing ulcerative gingivitis, so sometimes it occurs and it resolves on its own and can have milder pain, or it can be on a subacute stage where you don't feel something very urgent or very sudden onset. But there will be a history of constant radiating, gnawing pain, which may be aggravated by eating spicy, hot foods, or basic chewing process also. Symptoms can be sudden, then one of the most important factors which will be very useful when you write this in your examination, that is, it will have a metallic foul taste and excessive amount of pasty saliva. Patient may also have an episode of debilitating disease. Now, when we are talking about debilitating diseases, when we are talking about some systemic illnesses which deteriorate our health. Next, when we talk about the systemic sign and symptoms, so local lymphadenopathy, slight elevation in temperature, and when there are the severe cases of acute necrotizing ulcerative gingivitis, you can also have high fever, increased pulse rate, leukocytosis, loss of appetite, and lassitude. Lassitude means tiredness. Next, in first picture, you can easily see that there are some punch out crater-like depressions which are present on the interdental gingival region, on the interdental papilla. But interdental papilla may be the first sign or the first papilla to get involved, first part of gingiva to get involved. It also involved marginal gingiva. It also shows pseudomembranous slough and the gingival craters, which are demarcated from the healthy gingiva, right? So there will be a clear-cut demarcation between the pseudomembranous slough craters and the normal gingiva. Lesions may be denuded and the pseudomembrane exposes red, shiny gingival surfaces. And there might be bleeding on slight provocation. In 1977, there was also an author, Walter D. Shields. He conducted a study of some of the contributing factors of NERG in army population because army population and one of the most common debilitating factor for this disease may be stress. So they are divided into sign and symptoms, and there might be some primary and secondary sign and symptoms. So when we talk about the primary signs, they first is gingival bleeding. So because gingival bleeding, or you can say bleeding on probing, that is the first sign of gingivitis. Then it is followed by pain, interdental ulcerations, necrosis, especially in the mandibular anterior with resultant blunting and cratering. So the most important feature is punch out craters, pseudomembranous slug, and there is a clear-cut demarcation between the gingival margin and the pseudomembranous slug. So same blunting and cratering can be seen. Now, the secondary signs are pseudomembrane slugging, which I have already told you, fetid odor, bad taste, elevated temperature and malaise because lymph nodes are also involved, wooden sensation in the mouth, lymphadenopathy. Now, when we talk about the clinical course of this disease, so it had various clinical course. Again, when we are studying a particular disease, so there must be a sequelae, right? So that's why there were two terminologies, necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis, according to 2017 classification I'm talking about. So when necrotizing ulcerative gingivitis will proceed, it will eventually lead to necrotizing ulcerative periodontitis with progressive destruction of periodontium and gingival recession. So the severity and complications will automatically increase. Now, what are the stages and progression of NUG according to Pindberg et al.? So, first of all, there was erosion of only the tip of the interdental papilla. As I've already stated, that interdental papilla is the first papilla to get involved in this. Then it is followed by involvement of the marginal gingiva. And slowly and gradually, the attached gingiva is also affected. And when this necrotizing ulcerative gingivitis reaches up to the periodontium or up to the bone, exposure of bone can be seen. And then it leads to necrotizing ulcerative periodontitis. So that was according to Pindberg et al. But again, there was another person, Horning and Cohen. They have also staged it in certain types. First was necrosis of the tip of the interdental papilla, followed by necrosis of the entire papilla, then the necrosis of the marginal gingiva, then that particular necrosis extending to the attached gingiva, and finally up to the buccal and labial mucosa, right? And when these necrotizing or necrosis, they exposes the alveolar bone, the name automatically turns into necrotizing stomatitis, NS in the short form. And when these necrosis perforate the skin of the chick, when they involve the skin also, they are known as noma, right? Yeah, oral cancrum. There is another word to noma, that is oral cancrum. Next, what is the etiology? So, having an acute gingival infection might be because of certain etiological factors. So, first is your bacteria. As I've already stated earlier, that Borrelia vincenti and fusiform bacteria were the two most commonly involved bacteria in leading to acute gingival infections. So, first is there was a scientist named Plot in 1894 and Vincent in 1896. So they were the first who proposed this, that fusiform bacilli and spirochetes were the main etiological factor for acute necrotizing ulcerative gingivitis. Then Roseberry et al., they also confirmed it in his study that there might be some other fusospirochetal bacteria involved, such as Treponema microdentium, Treponema intermediate, spirochetes, vibrios, fusiform bacilli, filamentous organisms, Borrelia species, etc. Then, when we talk about the constant flora, so when we culture the necrotizing tissue, then the constant floras are Prevotella intermedia, Fusobacterium, Selenomonas, and Treponema. Next is, now there were different zone in its histopathology. So one zone was bacterial zone, where you can see the presence of zone while diagnosing this disease. Second is neutrophil rich zone. So in the bacterial zone, there was a large mass of bacteria, but having different type of morphotypes, including some spirochetes. When we talk about the neutrophil rich zone, so obviously there will be some kind of host defense system. So there will be leukocytes with neutrophils predominating bacteria, including other cells also. Then after that bacterial zone, and you know uh, there was a necrotic zone. So disintegrating cells and many spirochetes and other fusiform bacteria were also seen in the necrosis zone. And the last zone is spirochetal infiltration zone. So tissue elements appear well preserved but are infiltrated by a large amount of spirochetes. So the zones are like that. So neutrophil zone is there, bacterial zone is there, where constant flora can be seen, then followed by necrotic zone in which many spirochetes and many Prevotella intermedia bacteria can be seen, fusiformic bacteria can be seen, and then there is spirochetal infiltration zone where abundant of spirochetal bacteria can be seen. Next is what is predisposing factors. When we were discussing earlier, I've already stated that the necrotizing ulcerative gingivitis is also associated with certain debilitating disease. So those diseases become automatically a predisposing factors. The primary etiology was bacteria, and secondary might be some predisposing factors. So first is psychological stress. So in various studies, it has been found that the necrotizing ulcerative gingivitis is closely associated with psychological stress. Prevalence of necrotizing ulcerative gingivitis in military increases under conditions which produces high level of acute stress. That's why the first when these diseases were observed was observed in war zones, because there was high level of acute stress. And then again in drug addicts during periods of withdrawal, outbreaks of NUC can be seen among college students during examination, because that is the only time when we are taking a lot of stress. Then next is what should be the period of psychological stress. First is oral hygiene measures may decrease. So again, they are correlating it with our oral hygiene. So when we are under so much of stress, the first thing is we avoid our oral hygiene. We avoid our nutrition, because that also becomes very inadequate. Some people also have addiction of certain drugs, tobacco, smoking, that also increases. Because of stress, the immune function can also get suppressed. Stressful life events lead to an activation of hypothalamic pituitary adrenal axis, which is very important, because stress is directly associated with certain periodontal diseases, resulting in elevation of certain serum and corticosteroid levels. The next is there is increase in urinary level of 17 hydroxycorticosteroid, which has also been associated with stress. So when there are significantly higher level of such components in NUC patients when compared with the level measures after resolution of the disease. So there was a test done, and they found out that in a patient who had stress and a patient who is totally normal and is not under stress, so these urinary levels are, these corticosteroid levels are automatically increased, and they increase the inflammatory level of our periodontal tissues or the gingiva. So increased cortisol level may play several role in development of necrotizing ulcerative gingivitis, such as immunosuppression. Now, when we talk about immunosuppression, so we are correlating stress, increased level of corticosteroids, and then because of that, immunosuppression. So increased corticosteroid levels have been associated with in depression of polymorph neutrophil functions. So when we talk about neutrophils, so there are certain neutrophil function, because that is our first line of defense, right? So their function is Their function is to do chemotaxis, phagocytosis, oxidative burst mechanism को maintain करने में. So these function become depressed. Then there is another defense cell, that is lymphocytes. Their function is also altered. There are elevated steroid levels. They also provide essential nutrient for specific bacterial growth. So when the steroid levels increases, Prevotella intermedia like bacteria, they get a niche to grow. And then there are various studies which suggest that there is lack of protective antibodies in the development of necrotizing ulcerative gingivitis. Next, in a study which was carefully controlled for confounding factors such as plaque level, age, race, gender, socioeconomic status, a depressed, immunoglobulin G, M response in NUG subjects compared to control subjects were reported for 4 isolates of P intermedia. So earlier, what we were discussing, this is the study which just confirms the above statement. Then there it's another disease, that is HIV and AIDS. So NUG is also associated. So when you study about HIV and AIDS, you will see that necrotizing ulcerative gingivitis is one of the oral manifestation of that disease. Then next is malnutrition. So that occur in very young children related to poor protein intake, secondary to viral infections, for example, measles and protozoal infections. Then next is chronic diseases. As I was already telling you, that debilitating diseases, chronic diseases that lead to immunosuppression. So few diseases such as syphilis, cancer, gastrointestinal disorders, ulcerative colitis, blood dyscrasis, leukemias, anemias, and acquired immunodeficiency syndrome. These all are the debilitating diseases which are highly associated with, or they have necrotizing ulcerative gingivitis as their oral manifestation. Next is what features you can also see: deep periodontal pockets, pericoronal flaps. They are the vulnerable areas. So suppose if your oral hygiene is not proper and you're already vulnerable to develop gingivitis or periodontitis, and then again you have certain bacteria and certain other predisposing factors, then you are at a high risk of developing acute necrotizing ulcerative gingivitis. So now this is a flowchart. This is a very nice flowchart. Whatever I have told you earlier, this flowchart summarized or sum up everything. So psychological stress, anxiety, they just increase your steroid production, immunosuppression occurs, and viral infection can also lead to immunosuppression, which is followed by growth of bacteria. And if there is any pre-existing gingivitis, that is also adding it upon, and it is leading to necrotizing ulcerative gingivitis. Then what can other factors? First is immunosuppression can be because of viral infection, because of stress, because of deficient nutrition, viral infection, and HIV infection. And then there is a sequelae of necrotizing ulcerative gingivitis, which leads to necrotizing ulcerative periodontitis. And when the cheeks or the skin is involved, it becomes noma. So diagnosis is basically, एक तो हमने आपको clinical sign and symptoms बताए. So clinical sign and symptoms based diagnosis is there. So, and another is bacterial smear, because we can collect and culture and form a smear to differentiate between different other infections of the oral cavity, such as diphtheria, thrush, actinomycosis, and streptococcal stomatitis. We can use that specimen for biopsy, that gingival tissue or that necrotizing tissue, to confirm. And then there are various, what you call, there are various conditions that include gingival ulcerations as clinical features. The gingival ulcerations is not characteristic of NUG. Again, you have heard about differential diagnosis. So here, those differential diagnosis I'm confirming. For example, acute herpetic gingivostomatitis may also look like necrotizing ulcerative gingivitis, but there is a whole lot difference. Some bacterial infection may also look like that, such as streptococcal. So to confirm that, bacterial smear or biopsy specimen should be done. Mucocutaneous conditions and traumatic incidents can also, resemble like NUG and NUG. Then epidemiology and prevalence, it occurs at all ages, but highest incidence is 20 to 30 years, and in pubertal years, like 15 and 20 years. It is reported in areas which have low socioeconomic groups. In India, 54% and 58% of the patients in the two studies were under the age of 10 also. And If we talk about the contagiousness or the communicability, so communicability is basically referring to the capacity for the maintenance of infection by natural modes of spread. But this is a very non contagious disease. Disease is transmissible if it has the capacity of maintenance of an infection agent in successive passage through a susceptible animal host. So there is also a classical King's experiment. I think you should all read about that. In an attempt to spread NUG from human to human, so to confirm that it is contagious or not, or it is transmissible or communicable or not, the king traumatized an area in his own gingiva and inoculated the debris from a patient with severe case of NUG. But there was no response until he fell ill shortly thereafter, and subsequent to his illness, he observed the characteristic lesion of NUG. So the experiment demonstrated the role of predisposing factors. So to sum up the story, that there is no direct relationship, but because of his illness, that becomes a predisposing factor. He developed that disease. Treatment objectives very important. First is to resolve the acute phase, because in acute phase there will be bleeding, there will be pain, there will be so many things. Treatment of chronic diseases, for example, if there are any predisposing factors, syphilis, HIV, whatever acute involvement is there, treat them first. Alleviation of generalized symptoms such as fever, malaise. Systemic etiological factors correction is also required, such as to avoid stress, to avoid smoking, tobacco. Then first is there are sequence. So when the patient comes on the first visit, so complete evaluation is done. Medical history, illness, dietary, smoking, risk factor, HIV, psychological factors, everything should be evaluated. Then involvement of lymph nodes, especially submaxillary and submental. Patient should also be examined for the skin lesions. Then the pellet is to remove the pseudomembrane and the non-attached surface debris. Supragingival scaling. Again, I'm telling you, don't go for subgingival scaling, because you can spread the disease to other periodontal tissue. Suppose it's a case of necrotizing ulcerative gingivitis, and because of your trauma, because of your injury, because of your subgingival scaling, any debris or these bacteria, if it goes beyond gingiva, then they can lead to further diseases. Then extractions are postponed until the patient is symptom free. The time period usually required is 4 weeks for a patient to be symptom free. Then patient has to be placed on antibiotic regimen. First is amoxicillin 500 mg only every 6 hours for 10 days. If they are allergic to amoxicillin, erythromycin should be prescribed, and metronidazole 500 mg twice daily for 7 days can be prescribed. Then patient should be advised to rinse with 3% hydrogen peroxide mixed with equal amount of warm water every 2 hours or twice daily. And secondary is using a chlorhexidine mouthwash is a mandate. An analgesic such as non-steroidal anti-inflammatory drug to reduce the pain is also prescribed. Cleaning devices and ultra, suppose they cannot use a hard toothbrush, because that can cause trauma to their gingival tissue. So ultra soft toothbrush should be used. Patient should be advised to get adequate rest, avoid exercise, swimming, playing games, or any greater physical activity. Resolution of systemic sign and symptoms. The area of the lesion will be erythematous but with marked reduction of necrotic tissue. Scaling may be reperformed. Patient is instructed to follow the instructions. Then, after approximately 5 seconds of the second visit, I'm talking about the second visit, the patient is evaluated for resolution of symptoms, and complete protocol for periodontal management is planned. Again, hydroxyl peroxide rinse is discontinued, and chlorhexidine mouthwash is continued for 2 to 3 weeks. Then the patient is again told that they have to maintain their oral hygiene, counseling, nutrition, smoking cessation, and other habits if present, which can cause the reoccurrences avoided. Appointment should be scheduled for the treatment of chronic gingivitis, periodontal pockets, pericorneal flaps, elimination of all local irritants, including defective restorations. Patient should be evaluated after every 1 month for oral hygiene maintenance, because your job doesn't end there. The maintenance and follow up is the primitive thing which most of us dentists don't do. We're supposed to keep a check, keep a follow up to stop that reoccurrence. Then contouring of the gingival margin, because there will be craters. Then there might be a chance that patient is unable to take food due to pain, because this is a case of acute pain also. So multivitamin preparation along with therapeutic dose of vitamin B and C should also be prescribed. Disease resembles necrotizing ulcerative gingivitis. For example, there is also a disease known as desquamative gingivitis. So, patient with underlying systemic disease, for example, HIV infection, the inadequate local therapy, and patient compliance should be there. Let's talk about the second thing, that is primary herpetic gingivostomatitis. Again, it's also a kind of acute gingival infection. It is an infection of the oral cavity which affect most often infants and young children who are younger than 6 years of age. So the age barrier is there. Again, the causative organism is none other than the herpes simplex virus 1. Male and female are equally affected. Now, when we talk about the clinical features, so the primary infection is by the virus. Virus ascends through the sensory and the automatic nerves. They remain latent in the trigeminal ganglia, and then when the secondary manifestation is there, then you see the disease. And sunlight, trauma, fever, stress, because it had some kind of idiopathic etiology. So it have unknown etiologies. So it can be said that the virus can penetrate our body due to anything, sunlight, trauma, fever, stress, anything. Then secondary herpetic stomatitis can occur as a result of dental treatment. It presents as a characteristic vesicle at the site away from the site of treatment. So when we talk about how does it appear, so it looks like discrete spherical gray vesicle of the gingiva present in the labial and the buccal mucosa, can also be seen on soft palate, pharynx, sublingual mucosa, and the tongue. But it has a whole lot difference with the ulcerations, or what you call aphthous ulcer. After approximately 24 hours, the vesicle rupture and they form painful small ulcers which are red elevated, halo-like margin and a depressed yellowish or grayish white central portion. They also appear as diffuse erythematous cyanide discoloration and edematous enlargement of the gingiva, and they have tendency to bleed. But most important that most of the cases of acute herpetic gingivostomatitis, the lesion resolves on its own. The lesions are very painful. That's why I'm calling it acute infection, sudden infection, right? So painful, and they are very sensitive to touch, changes in temperature, and to food, beverages, especially the spicy food and fruit juices, and to the action, of course, food is there. There is also involvement of cervical adenitis, high-grade fever, and generalized malaise. Let's come to diagnosis. So the diagnosis in most cases can be stabilized by history and clinical examination. The confirmatory tests include, first of all, the etiology is virus, so virus culture, some immunological test, which can also include monoclonal antibodies or DNA hybridization test. Let's talk about the histopathology, because there are certain other diseases which resembles the acute herpetic gingivostomatitis. So histopathology is the only test which differentiate between the acute herpetic gingivostomatitis and its other differential diagnosis. So epithelial cells show ballooning degeneration, acantholysis is seen, nuclear clearing is seen, nuclear enlargement, and the presence of Jang cells. Cell fuse forming multinucleated cells, intercellular edema, intraepithelial vesicles which rupture and develop a secondary inflammatory response with a fibropurulent exudate. Differential diagnosis, again, necrotizing ulcerative gingivitis, recurrent aphthous. मैंने आपको बोला that it may resemble like aphthous ulcer because of halo-like margin, erythema multiforme, Stevens-Johnson syndrome, bullous lichen planus, desquamative gingivitis. So one of the most, this chart which I've included is to differentiate that how necrotizing ulcerative gingivitis is different from acute herpetic gingivostomatitis. So first is the site of ulcer. So when we talk about the NUG, it only involves the interdental papilla and marginal gingiva. But when we talk about the acute herpetic gingivostomatitis, then it involves gingiva, but there is no particular predilection for interdental gingiva. Entire oral mucosa can be involved. When we talk about the ulcer characteristics, so the nug has punched out, crater-like, yellow, white, grayish, sluggish, spontaneous, painful, and simulation kind of ulcers. And when we talk about this, the multiple vesicles that coalesce to form shallow, fibrine covered, regular shaped, no marked tendency to bleed, and no spatially tender. So this chart will help you in exams because if you remember this chart, you will remember all kind of sign and symptoms, site of ulcers, what are their clinical features, diagnostic features, etc. When we talk about fever, they both have this similarity. When we talk about symptoms, so they have painful gums, dead feeling teeth, and these have sore mouth. Duration of ulcer, short lived, 1 to 3 days, and they subside with appropriate therapy. And here the duration is more than 1 week, and they can't even subside even with therapy. So these are the two pictures which clearly shows the, can you see that these are your deciduous dentition? Again, etiology is also, there is a difference. So if we talk about the etiology for acute herpetic gingivitis stomatitis, so viral etiology. And again, I told you a word, idiopathic. So etiology is unknown, suspected immunopathological mechanism, no diffuse involvement of gingival, isolated ulcers can be seen. And when we talk about the sites involved, diffuse erythematous involvement of gingiva, unlike necrotizing ulcerative gingivitis. Lesion less than 1 centimeter will heal without scarring, and lesion will heal without scarring. Then again, I talked about one particular disease, that is desquamative gingivitis. So when we talk about these two diseases, the basic difference is the etiology only. Desquamative gingivitis can be caused due to bacteria, while primary herpetic is caused due to viral infections. But the sites are involved almost equally in both the conditions. But here, gingiva does not peel, while in desquamative gingivitis, peeling can be seen. And again, desquamative gingivitis is not at all an acute condition, while the primary herpetic gingivostomatitis is an acute condition. Next is another differential diagnosis, that is erythema multiforme. So again, but it also involves tongue, skin lesions, large vesicles. Then Steven-Johnson syndrome, it is also a form of erythema multiforme, which can be confused with acute herpetic gingival stomatitis, but they have hemorrhagic vesicular lesions in oral cavity, and they also involve skin and eyes. Because it's a syndrome, bullous lichen planus, prolonged indefinite course of disease, painful condition, oral lesion, coexistent with skin lesion. So whatever lesions I'm talking about, which are the differential diagnosis for primary herpetic gingivostomatitis, they are, vesicobullous lesion, and they also involve skin. While acute herpetic gingivostomatitis does not involve skin. Then, when we talk about the treatment, so previous treatment of acute herpetic gingivostomatitis consisted of only supportive care. So recently, some antiviral like acyclovir therapy have been given for 5 times daily for 7 days, 15 mg per kg. Valacyclovir, famociclovir, these are some, antiretroviral therapies. The antiviral therapy, they reduces symptoms like fever, difficulty in eating, also decreases the appearance of new extraoral lesion. Antiviral therapy is found to be effective only if the lesions are diagnosed within 3 days of onset, because these lesions are supposed to heal by their own. The patient reporting after 3 days of onset should be given a palliative care. This is a very important part. Removal of plaque and food debris, administration of NSAIDs to reduce fever and pain, nutrition supplements. Periodontal therapy should be postponed until the acute, because in acute cases, any therapy is going to, just mold the disease. So periodontal therapy should be postponed until the acute symptoms subside. Herpetic infection, herpetic whitlow. It's a very important term. You might encounter this term in your regular practice when you start practicing. So, infection on the finger can occur. Suppose there is a clinician and they are dealing with the patient of primary herpetic gingivostomatitis without knowing that this patient is having herpetic infection, right? And they're not wearing gloves, or somehow our fingers came in contact with those viruses. So that infection, when a clinician fingers are involved because of patient herpetic lesion, so that is known as herpetic whitlow. So it is infection of the finger which can occur if a seronegative clinician becomes infected. So this is utmost important for clinician point of view. Next topic is pericoronitis, which you all what you call the case of operculectomy, very commonly, which is generally or mostly seen in the third molar region. Pericoronitis refers to the inflammation of the gingiva. Again, it is pericoronitis. So the name itself, peri means surrounding, coro means the crown of the tooth structure, and itis means inflammation. So inflammation of the gingiva or a pericoronal flap of an incompletely erupted tooth. Again, the incompletely erupted tooth, if they have a pericoronal flap just above it and it is inflamed, and that's why the most commonly tooth involved is the mandibular third molar. You can see in this picture that how the flap is upon the coronal portion of the tooth, and because of impaction of food and bacteria, the swelling and inflammation occurs. Next is space between crown and pericoronal flap. So that becomes an area for bacterial colonization. And because of that bacterial colonization, inflammation and ulceration of flap is seen. And because of that inflammation, there is increased bulk of the flap due to inflammatory edema. You all must be aware about the procedure, how inflammation exists. So the pericoronal flap will be seen as red swollen with presence of exudate. Again, presence of exudate is that maybe, may not be. That depend on how acute the lesion is. Pain should be radiating to ear, obviously, because there is involvement of mandibular third molar. Sometimes the pain can also radiate to throat, floor of the mouth. There is trismus, inability to open the jaw, foul taste, swelling on the cheek in the region of angle of jaw. Patient is not able to open mouth, chew anything, eat something. Lymphadenitis may be seen, and in very severe and acute case, fever and malaise is also present. Again, it is called as acute infection because it is also again a case of sudden pain, sudden onset, rapid onset. So, in necrotizing ulcerative gingivitis, when we were discussing about the sequelae. So, here also we'll be discussing about the sequelae of pericoronitis. So, if pericoronitis persists and it is not treated in the given time, then it can also lead to pericoronal abscess. It can reach to peritonsillar abscess in the tonsillar area. In heavy cases, it can lead to cellulitis, and again, if it involved some spaces, it can lead to some space infections such as Ludwig's angina. Treatment largely depend on the following factors. Yeah, first is severity of inflammation, how acute the lesion is. Next is how systemically involved it is. If lymphadenitis is there, tonsils are involved, or spaces are involved, and the possibility of retaining of the tooth. Again, if it is impacted, horizontally impacted, vertically impacted. So the position of tooth is also very important. The acute pericoronitis is treated to relieve the acute system so that at least the patient can eat. So gentle irrigation of the area with warm saline to remove the debris and exudates. Occlusion is evaluated to determine if an opposing tooth is occluding with the pericoronal flap. So that pericoronal flap should be removed. Occlusal adjustment is necessary in case of opposing tooth traumatizing the flap. Next is antibiotics should be prescribed in severe cases when the lymph nodes are also involved because of severe pain and acute infection. Drainage can be established if swelling is fluctuant by using a number 15 blade. If there is immense swelling, fluid inside it, then that drainage of that pus should be done. After resolution of the acute symptoms, the tooth should be evaluated for possibility of erupting. If it is possible that that tooth can properly erupt into the oral cavity, then that pericoronal flap should be removed. If the tooth is to be retained, the pericoronal flap should be surgically excised using periodontal knives or blades, surgical blades. But if the removal of the flap should result in a site which can be easily maintained by the patient, to ensure this that the flap covering the occlusal surface as well as the tissue distal to the tooth has to be removed. There should be not a single tissue because gingiva regrows, the flap regrows. So we have to take care that that particular operculum, that flap should be removed. Uh, Next, one more before concluding my topic, I want to also explain that if the tooth is horizontally or vertically impacted, then the tooth should be removed. So, finally, I'd like to conclude this PPT. Hope you liked it and enjoyed it. But trust me, these kind of infections are very prevalent epidemiologically and on the basis of prevalence also. in our population. So these require utmost care, patient counseling, stress management, knowledge of, to redefine that how you can differentiate between certain diseases. So acute gingival infections, they required an accurate diagnosis so that appropriate emergency can be provided to relieve the patient's symptoms of pain. Careful follow-up of the affected areas is essential for the avoidance of recurrent problems. Exactly, a better clinician is that who keeps the follow-up and avoids the recurrency, which can lead to further soft and hard tissue destruction. Thank you. For references, I have used very basic and minimal your Carenza. And yes, keep smiling.